Good evening, everyone. Today we are back with another case on endometrial polyp. This is the 13th case of the gynecology series. Our patient is a 48-year-old female. She had complaints of intermenstrual bleeding for 2 months. The bleeding usually involved fresh red blood and it lasts for 1 to 6 days. Episodes of bleeding occur any time in the cycle and she faced no hot flushes or night sweats. These are the symptoms observed usually in menopause, and she is sexually active and has not noticed vaginal dryness. Pregnancy status: she has 3 children. Medical and medication history: she uses the progesterone only pill for contraception for 5 years. Her last smear test was 2 years ago, and all smears have been normal. She takes no medication and has no other relevant medical history. On examination, the abdomen is unremarkable. Speculum examination shows a slightly atrophic looking vagina and cervix, but there are no apparent cervical lesions and there is no current bleeding. The patient's cervical smear was also normal and no lesions were observed, so a cervical pathology or etiology is mostly not the case. On bimanual examination, the uterus is non-tender and of normal size, axial and mobile. There are no adnexal masses. The lab parameters involved hemoglobin, WBC and platelets, all of which was normal. Specialized diagnostic tests, a transvaginal ultrasound scan and hydrosonography was performed. In this, saline is usually filled in the uterine cavity and observed under an ultrasound scan. So polyp was noticed in this. So we can suspect that the patient was maybe suffering from an endometrial polyp. Assessment: the final diagnosis is of an endometrial polyp as shown by the hydrosonography image. In this specific case, all the differential diagnoses are effectively excluded by the history and examination. A little brief about endometrial polyp. It occurs in women of any age, though it is more common in older women, and it may be asymptomatic or cause irregular bleeding or discharge. The etiology of endometrial polyp is unknown, and the majority are benign. Now, the differential diagnosis for intermenstrual bleeding involves cervical malignancy, also known as cervical cancer. In this case, cancer was ruled out since her cervical smear was normal. There were no lesions found. Cervical ectropion. So this condition involves the columnar cells that usually lines the inner walls of the cervix. It starts to grow in the outer walls, and those columnar cells are glandular, so they have certain secretions. This this secretion causes an abnormal discharge in the patient, but in this patient there was no discharge observed. There were no cervical lesions observed, and in cervical ectropion, the cells that grow on the outer wall of the cervix is usually redder and inflamed. No inflammation was observed in the cervix in our patient, so we can rule out cervical ectropion. Endocervical polyp: there was no polyp observed in the cervix, so this is also not the case in our patient. Atrophic vaginitis: it is the inflammation of vagina due to tissue thinning, caused mainly by the lack of estrogen. So there was no inflammation observed in the vagina. Pregnancy: an irregular bleeding related to the contraceptive pill. Signs and symptoms: vaginal bleeding after menopause, bleeding between periods, frequent and unpredictable periods, menorrhagia, and infertility. The need of therapy in this patient is to provide symptomatic relief and to improve patient's quality of life. Before learning the therapeutic management in this patient, let's learn a brief about the disease. About the disease, an endometrial polyp or uterine polyp is a mass in the inner lining of the uterus. They may have a large flat base, sessile, or be attached to the uterus by an elongated pedicle. It's called pedunculated. So, pedunculated polyps are more common than sessile ones. They range in size from a few millimeters to several centimeters. If pedunculated, they can protrude through the cervix into the vagina. Small blood vessels may be present, particularly in large polyps. So, pedunculated and sessile is mostly differentiated by the surface area of the polyp that is attached to the uterus. If there is a long stalk like structure which is attached with the polyp and the uterus, then these kind of polyps are known as pedunculated polyps. But if it's more flat and it's directly attached to the uterus, those kind of large flat based polyps are known as sessile. Where these polyps occur, symptoms include irregular menstrual bleeding, bleeding between menstrual periods, excessively heavy menstrual bleeding, also known as menorrhagia, and vaginal bleeding after menopause. No definitive cause of endometrial polyps is known. As it was mentioned earlier, there is no known etiology for this condition, but they appear to be affected by hormone levels and grow in response to circulating estrogen. Risk factors include obesity, high blood pressure, and a history of cervical polyps. Endometrial polyps can be detected by vaginal ultrasound, sonohysterography, hysteroscopy, and dilation and curettage. Hysteroscopy it allows the surgeon to observe a uterine cavity by using endoscopy, and dilation and curettage it is a diagnostic test where the cervix is dilated, and then curettage is the removal of a tissue to observe for any possible abnormality. Detection by ultrasonography can be difficult, particularly when there is endometrial hyperplasia. Larger polyps may be missed by curettage. Let's learn about the management and intervention. Any women should be investigated if bleeding occurs between periods. In women over the age of 40 years, serious pathology, in particular endometrial carcinoma, should be excluded. The polyp needs to be removed for two reasons: to eliminate the cause of the bleeding and to obtain a histological report to ensure that it is not malignant. Since polyps are usually benign, but it may also be malignant, so a histological report is very important to rule out the malignancy of the condition. Management involves outpatient or day case hysteroscopy and resection of the polyp under direct vision using a diathermy loop or other resection technique. A diathermy loop resection is a procedure in which a small wire loop with electric current is used to remove the tissue, and then that area is sealed to reduce the bleeding. This allows certainty that the polyp had been completely excised and also allows full inspection of the rest of the cavity to check for any other lesions or suspicious areas. In some settings where hysteroscopic facilities are not available, a dilatation and curettage may be carried out with blind avulsion of the polyp with polyp forceps. So, as I had mentioned earlier, dilatation and curettage is a procedure to diagnose the tissue. So we dilate the cervix or the uterus, and then we curettage means to remove a part of the tissue and then observe for any abnormalities. Blind avulsion is the removal of a polyp using forceps. So this was the standard management in the past, but it is not the gold standard now. This image is hysteroscopic appearance of endometrial polyp prior to resection. So this is how a polyp appears in hysteroscopic procedure, and then it is removed by either a diathermy loop or other methods. So that's it for today's session. Thank you for watching and please share this video. Thank you.